Okay, everyone. We are going to start this session. Planned a better break in between this one to make sure that everybody has time to navigate down to Emerson. So we might take a little bit more time. Lunch might be a couple of minutes late, but not the end of the world. So again, we have Dr. Sonia Ballal here, who is going to talk about GI presentation. So, Dr. Ballal.
Thank you, Jeff, and thanks to the organizers. Thanks to all of you for being here. I am tempted to leave and go hear the other talk too because it sounds really good, so I'm going to have to see the recording of that later on, but I appreciate you all being here as well. So just as Jeff mentioned, I am a gastroenterologist. I'm at Boston Children's Hospital. Can you hear me okay? Okay. And I'm going to be talking about GI concerns in Kleefstra. Talk to my slides and talk to you at the same time, so I'm going to turn a little bit this way. I have no major conflicts of interest. Some of my work is supported by the foundation and philanthropic donations from individuals. I want to start by thinking about learning objectives. Okay. My hope at the end of this talk is for you to realize what I think is really the biggest resource when it comes to good GI care, and that is collaboration and partnership. And so what I'd like to do is go through the most common GI concerns in children with Kleefstra, understanding the complexities around this when it comes to the GI tract, and also thinking about how can we learn from other disease states, for example, autism. Are there things that we can learn about the GI tract in Kleefstra in thinking about the GI in children who have autism? I think Jeff mentioned in the previous presentation kind of the importance of drawing from that parallel, and I want to continue to do a little bit of the same. Finally, I want to talk about strategies to optimize GI care for KS patients and some of the things that we're doing. And I really would love your input here too. What are things we can do more of to make it even better? So let's start with this picture. This is a picture I think about pretty much every day of my life these days. This is the human GI tract. It is one long tube. It goes from your mouth, where food goes in, sometimes, down to your esophagus, from the esophagus, which is also the feeding pipe to the stomach, to the small intestine where all the nutrients get absorbed, which turns into the large intestine, or also known as the colon, and then you have an anal opening at the end. One long garden hose. This is the analogy I often use to talk to my patients. One long garden hose coiled up inside you. Seems pretty straightforward. But then you start to layer in some things. The GI tract is entirely lined by muscles. Muscles, some voluntary, some involuntary. They do different things. So just like any muscles, they're going to be impacted by things that impact muscles, like hypotonia. So just kind of star that little comment in your head, okay? Nerves. The enteric nervous system rivals the central nervous system, the brain and spinal cord in terms of its complexity and its size. There's an entire nervous system just within the GI tract. Gut hormones. Those are little messengers running around in your bloodstream telling different parts of your body what to do. All of this is also being produced within the GI tract by different specialized cells. Not cells anymore. Then you've got another layer. You've got an immune system, which is heavily prevalent in the GI tract. There's a layer of mucus or mucin that's in the GI tract, which might just seem like kind of a layer of snot spread out in the GI tract. It's not. It's actually a really important immune system. There are complex armies of cells in the innate immune system and the adaptive immune system that need to work together. And then the gut microbiome. We're never alone, not just in this room, but in general. Even if you're alone in a room, for every one human cell, there are at least 10 microorganism cells. We are completely outnumbered. And a lot of that has to do with the microorganisms that are in the GI tract. And finally, the gut-brain axis. So thinking about how the brain, the GI tract, and even the microbiota all sort of interact together is an important part in thinking about the GI tract. So I took us from this garden hose that's really simple and an easy analogy to think about, but when you layer on all these pieces, clearly it is very, very complex. About the gut microbiome, the gut-brain microbiota axis. At the bottom is the best and most accurate representation. This idea of a highway with multiple crossings in multiple directions. The different parts of this axis are the brain, the GI tract itself, and the microbial inhabitants that I just started to talk to you about. And what I'm saying to you is in the gut-brain axis, there's tons of crosstalk. It's coming in all directions, and it's coming in different ways. We have different metabolites, like short-chain fatty acids, tryptophan metabolites that are produced in the gut, and then they travel into the bloodstream and are important for how nerve cells mature. We have different pathways that are mediated, made looser or tighter based on disruptions in the GI tract, which is dysbiosis. We have a lot of signaling back and forth with the nervous system, too. I was talking to you about the enteric nervous system just a minute ago. The vagus nerve, which is a very important nerve in the entire human body, runs down towards the GI tract, and it's getting signals back from the GI tract that it's sending up to the brain. And this is happening continuously. So there is a ton of back and forth between the brain, the nerves, and the GI tract. And the microbes in our body are part of that interaction. And all of this together is what is termed loosely the gut-brain axis. Has anyone ever Googled that term? Has anyone ever seen that term before? Yeah, it comes up a lot, especially when we're talking about neurodevelopmental diagnoses. So the first thing to do is understand, what are they even referring to? What we do think is that when there are disruptions in these interactions and in these conversations between these different parts of the gut-brain microbiota axis, that we can actually have disease states form. So, for example, we can think about functional bowel disorders like irritable bowel syndrome. I see tons of that in kids who have neurodevelopmental diagnosis. And we think this might relate to a disruption in that gut-brain microbiota axis. Mood disorders. There's some thought that there could be some connection between the GI tract, the gut-brain axis there as well. And then finally, neurodevelopmental disorders, including autism. It is widely believed, and there's quite a bit of literature to support, that autism might be related to a disruption in this gut-brain microbiota axis. And just like we spoke about in that previous discussion and talk, comorbid autism is highly prevalent in KS, and I think many of you would agree with that. I probably could have left this slide out because I think all of you understand the definition. I consider you much more the experts in this area, but I think it's important just to review that we're talking about a gene that is a key regulator of neurodevelopment where it is not working the way we hope it would work. And as a result, we can see a clinical phenotype which includes hypotonia, seen in 17 out of 17 of the individuals in that previous presentation, distinctive facial features, and sometimes intellectual disability. And as we can see just from walking into the lobby of this hotel, there is a huge spectrum with all of that. So I think it is really hard to completely define this syndrome without acknowledging what a wide spectrum it is. There are also some important systemic manifestations: cardiac, which was mentioned in the previous talk, some renal manifestations, and then the things that I focus on most, which are the GI diagnoses. What are these GI diagnoses? Anyone here know a kid with KS who has constipation? All right. I could do a quick survey of the room, but I'm going to tell you right now, percent. And what the data is looking into it a little. And so I want to give you some of the out there. First group. Come over here first. we've got a denominator of 94, and you can see that in that group, 41.4% report mild or severe constipation. I might just take this over here. Can you still hear me? In the second group, we have a cohort of 65 individuals, and in that one, we have a lower rate of constipation that was reported, 31%. I'm not sure if I totally buy that. I think it's higher than that in general. In this last cohort of 108 KS patients, so remember the denominator is all KS patients. This is pretty great to think about it this way. 108 KS patients, 70 out of the 108 reported constipation. Let's delve into that 108 just a little bit more. This is a medical student that I worked with last summer, and we looked at a cohort of individuals with KS. Dr. Sid, who many of you know and who's speaking tomorrow, is a colleague of mine, and we work together. And we're working and thinking about what are the GI manifestations of Kleefstra? Can we understand this a bit more? So I had a medical student, we had a little grant from my GI society, and she worked on this last summer, where she went through all of these medical, started to tease apart what are the GI symptoms, what are the GI diagnoses that we're actually seeing for these patients. So she did a deep retrospective review of the electronic medical records. You can see that we have a pretty good split of male and female with these 108 patients. The graph at the bottom shows the age distribution. We certainly have quite a few who are under 3, but we definitely have our share of teens as well. And then what are the results? Constipation, that's where you get your 70 out of 108. Feeding difficulties and oral aversion, also 60%, that's kind of in the top 3. And then some concerns around weight and nutrition, with overweight being an issue in 50.9% of the individuals in this cohort of 108 kids with KS. There's also acid reflux, which is pretty high, 38.8%. And this was what we presented as an abstract last year at our society meeting. We're still working on the publication of this, but I think this is starting to be really interesting. We're seeing some things emerge. So this is a Boston-based cohort. Many of these patients may be from Boston or the area nearby. Many may travel to see us in the KS clinic. What about in other places? It's an Australian-based cohort, and this isn't my favorite picture, but I just got a copy of this poster this week because Steffa Miko, Emma Palmer, and their group in Australia presented this at a rare diseases abstract, and I wanted to share it all with you. This is an Australian-based cohort of patients with KS, 28 patients included, did a similar thing where they took a look at the reviewed the electronic medical records. And look at what they found. 82% of these 28 patients had at least one. 82%. And then the top contenders were constipation, gastroesophageal reflux disease, feeding difficulties. So we're seeing lots of things. We're seeing some of the same themes pop up from around the world, but we're also seeing that this is a real problem. This is something we actually really need to think about more deeply. I want to pull you back for a minute away from the clinical manifestations and start thinking about why, because if you're anything like me, you're starting to think about that already. We talked a little about why, which is the gut-brain axis. I want to talk about another why, which is thinking about the microbiota. And this study, I think, is an important one for you to be aware of, because I think there's a lot of talk about how is the microbiome involved when it comes to KS? What impact does it have? And that's exactly what these researchers were trying to understand. So they obtained fecal samples, so stool samples, from 63 individuals, 23 of them with KS, 40 family members. And then they wanted to say, if we analyze these two groups, their stool samples, can we see differences between the two groups that are able to help us distinguish between them and say this is a stool sample from a KS individual versus someone versus a family member? That was their goal. So they sequenced all of these stool samples, which means that they looked to see who's there, who are all these microbial inhabitants taking over actually there. and that's called membership or composition. So they went through and did that, and what they found was that for those with KS, it actually does look a little bit different. It does seem like there is some alpha diversity index that's a little higher, which means that you can distinguish between the KS and the family members in this particular study. That's really interesting. Well, what are some of the distinguishing differences between these two groups? One is that Coprococcus 3 was lower in those with KS. This is one particular bacterial group. Meritobacter was lower in those who had KS and GI symptoms. So could we potentially think about that with GI symptoms? That's sort of an interesting piece of knowledge too. So let's take a step back. This is an experiment, and it's a great one, and it's really interesting data to draw from it. Potentially there is a microbial signature when it comes to KS. Potentially there is a way to think about the microbiome when it comes to KS. However, and potentially we could think about it even related to GI and behavioral severity. And that's also really interesting too. But the authors very intelligently admit this is still a small sample size for a microbiome study. So we have to be really cautious in drawing too many conclusions too quickly. It is a cross-sectional study. It notes association, but not causal direction. So what that really means is there are tons of confounders and that they were not able to take into account. Who's on antibiotics? Who's on probiotics? Who's on constipation medications? What kind of diet do you have? Because we know all of those things can impact these types of findings too. So I think we take this as something interesting and file it away. We need more data here, okay? But lots of interesting stuff when it comes to the microbiota. Let's go back to thinking about some of the actual problems we're seeing in our kids. Constipation's a big one. It's not just constipation. A list here, this is not exhaustive. There are lots of things that are not on this list. But this is just what I find in the literature. I find in discussions with colleagues around the country and around the world who are interested in taking care of KS patients. And it's things I've seen in my own clinical experience. So there are lots of different types of GI problems that can happen in kids with KS. Let's focus for a minute on the top one, feeding difficulties and oral motor dysfunction. This is also a great study. This is a study of 103 individuals with KS, and it's part of that group in Australia as well, and Dr. Kleefstra, of course. And thinking about these 103 individuals, where does feeding come in? Is here. Feeding impairment was noted in 34% during infancy, 73% during early childhood. That means 73% of this cohort of 103 patients had some type of feeding issue during early childhood. And many of you might agree with that in your own personal experience. 40% had issues with feeding even greater than 8 years of age, if there was follow-up data for those patients, or it might actually even be higher because there was not follow-up data for everyone. 10% had nasogastric feeds. Does everyone know what nasogastric feeds are? A tube that can be placed exactly from the nose down to the stomach. And gastrostomy feeds. Does everyone know what gastrostomy feeds are? That's more of a surgical placement of a tube where you can directly go into the stomach to give feeds. That's 15% who have some type of a supplemental enteral form of feeding. That's pretty high when we think about it. So this is something that our community needs to be aware of, and our parents, patients need to be educated on. Feeding problems are common, even more than constipation, though I think we could all argue on that, and for some can remain an issue throughout childhood. So this is an important part of thinking about the GI tract in KS. Why might feeding be difficult for patients with KS? Well, we talked about hypotonia, right? We know that there are issues with motor and development factors that can certainly impact feeding, and I think KS is no exception here. We can have oral motor coordination challenges and delayed feeding skills. There are also concerns around swallowing and airway protection. The suck-swallow mechanism is actually quite difficult to maneuver. Suck, swallow, breathe, all at once. It feels like it should be pretty simple until you really think about it. And I'll give you an example. One of the hardest textures a speech pathologist has taught, hardest textures to ingest is actually cereal and milk. because you've got solid, liquid at the same time, moving at different rates in your mouth, trying to swallow it and breathe. And when you really think about it, you're like, wow, that bowl of Cheerios with milk, how did I do that? It's pretty hard, actually. There's a risk of oropharyngeal dysphagia, so laryngeal cleft, which is an anatomic abnormality that sometimes is detected by our colleagues in otolaryngology. There's a risk of aspiration that might make feeding difficult. There are lots of GI factors that can make feeding difficult. Gastroesophageal reflux or other types of reflux, non-erosive reflux disease, eosinophilic esophagitis, altered motility in the GI tract, both the upper GI tract and the lower GI tract can actually impact feeding. What we know is that feeding problems are likely multifactorial and they're dynamic. They likely change over time. So having someone who can help guide you through the evaluation at different points in your child's life is really important. So how do we approach feeding difficulties? The word reflux is thrown out there a lot. But when you look at some of the data, like the 103 patients, only 12% were actually acknowledged as having reflux, but a lot of them had feeding difficulties. So what else is causing it? Well, there could be a whole variety of things. So this is a chart that I put together with some common signs and symptoms that I see in patients, and then possible diagnoses, not definite diagnoses, but possible diagnoses that could be associated with it. For example, coughing, choking, gagging with eating or drinking, watery eyes while drinking. Sometimes that can be associated with oropharyngeal dysphagia or swallowing dysfunction. If you have a child who has recurrent respiratory infections, possible aspiration or oropharyngeal dysphagia can be an issue. Sometimes painless regurgitation, sometimes regurgitating contents into the mouth and re-swallowing those contents, which we can see actually not uncommonly. This could be rumination. Feeding refusal that's also accompanied by intermittent abdominal distension or hard stools. Even though it presents as feeding difficulties, it actually might be constipation. And then when you think about someone who has feeding difficulties, we often worry about slow or poor weight gain. And what does that actually mean? And that could just mean inadequate intake. It could mean an issue of absorption. But there's also a risk of micronutrient deficiencies. And I will tell you, for kids who have very narrow specific diets, I see this not infrequently. I was just on the phone about an hour ago about a patient with super low vitamin A and vitamin D on the edge of whether or not we need to admit to the hospital to replete that deficiency. And it's based completely on a very narrow diet. So even in this country, and guess what percentile that patient is? 90th percentile for weight. So it can be really normal weighted individual who still has micronutrient deficiencies. So you need to have someone help you tease apart some of this. It's not a one-person job. Diagnosing and treating feeding difficulties in KS is certainly a team sport. Your first line, I will always bow my hat, tip my hat, bow my head, I always forget these expressions, to your child's pediatrician, primary care provider, and peer PA, because that person is at the front lines of hearing all of these concerns and helping us filter what needs that next step. Might require a referral to a gastroenterologist like myself, or adding in a nutritionist, a dietitian who's this type of care, or an otolaryngologist, an ENT doctor. That person can be really important in thinking about causes of oropharyngeal dysphagia, or a feeding specialist. Also, I think should be a requirement for any work feeding difficulty. Possible tests could include blood work, labs, stool studies, an ultrasound, fluoroscopic procedures, and then, of course, procedures such as an upper endoscopy, which gastroenterologists do frequently when needed, bronchoscopy that pulmonary doctors do, or direct bronchoscopies, which ENT doctors do. And sometimes we do all three at once. So this is where it's really important, and that's not uncommon in my hospital, that we will do all three at once under one anesthesia to try to exposure for our patients. So we talked a little bit about different manifestations of GI issues in KS, and I mentioned to you earlier that I want to draw from the literature and experience from another neurodevelopmental diagnosis. So let's think about that a little bit further. Children with autism have higher rates of GI problems than counterparts who do not have autism. This is something that you, as experts in a neurodevelopmental diagnosis, intuitively know, but it's important to think about the data, because once we start to quantify something like this as a problem, really delve into how do we fix it. Lots of parent groups of children with autism have also said the same thing. GI problems are a big deal. Some smaller studies looking at the prevalence of those GI problems. This is probably studies, and I quote it all the time. This is a 2014 study by Dr. Barb McLennan from Atlanta. She's also a gastroenterologist. She did a meta-analysis where she looked at all of these individuals, 2,000 kids with autism and controls, and said, okay, is there really a higher rate of GI problems in these individuals? And I showed you cohorts for KS individuals, right, around 8 in the 70s, in the 60s, patients. Is there really a higher rate of GI problems, or is this something that just we're focusing on as caregivers and healthcare? What she concluded is something that I quote to families frequently. If you have 4 times more likely to have a GI if you do not have autism. And I find that statistic very helpful for many families. It is affirming to know that their observations are not anecdotal, they're not isolated, but they're really backed by a lot of science. So if we know this, what else can we do? How can we approach? Well, we know that there's a greater prevalence of some GI complaints and disorders. Classic GI symptoms, a patient who might say, yes, I have heartburn here, and think about reflux. But the truth is, when you have a neurodevelopmental at the same time, you may have atypical presentations of GI problems. So you might have increased repetitive behavior, have aggression to self or to others, and that might be increased. And having those sort of subtle conversations around the history is really key for uncovering what might be the GI problem that's going on. Asking how a child shows pain. This is an important question to me. As a gastroenterologist even, I ask this of all of my patients and their families, their parents and caregivers. How does your child show that they are in pain? Because almost every parent has some observation around that. And I want to know what that is, because we need to understand some of those patients. Non-judgmental approach when it comes to talking to our patients and our patient families, that's key. Creating a treatment plan that can be accomplished, that has some doable goals, but also has operational. What would you wish for your child? What's our plan for the next 6 months? We need both of them. There's got to be collaboration there. I like this quote. This is from 2010, where there was a consensus statement, admittedly before I was in this field, but I still think this is a really important quote to elevate every single day of my job, to be honest. And this is a consensus statement that was put out by our National Society of Gastroenterologists about caring for children with autism and GI problems. And the statement is that these children deserve the same standard of care in the diagnostic workup and treatment of gastrointestinal concerns as should occur for patients without these disorders. And I would apply this statement to every single patient with KS as well. So what can we do to actually offer this robust GI care that I'm hopeful for? So I'm going to give you a couple of examples of things that we're doing at my hospital, and I'd love to hear ideas of things that you might have from your experience too. One is optimizing the ambulatory care visit, 2, educating a pipeline of healthcare professionals, and then collaboration with colleagues. So let's talk about each of these things. Optimizing the ambulatory care visit. That starts before you even walk into the room. You want to know the patient, you want to know where they've been. That's been done, certainly. And a little bit about wanting to understand pain. How does it pain? But I also kind of want to know how to communicate. What we did was create with speech visual tasks that are specific GI visits and our visits. And we create task lists, patients structure the visit themselves. So they are able to move pieces over from the left side over to the right visit. As we go, kids know exactly what's happening. I tell you, they keep me on time when it is complex things. NG tubes, changing these things are really relevant to our visit. Our question really work. We did some testing. We asked some questions. We asked these parents, does this make a difference for you? So the columns in blue are surveys that were done before the visit with the visual task list. The columns in peach are the surveys that were done after the visit with the visual task list. And then we asked them about their understanding, anticipation. Did it change the list in place? And what parents reported was that VTLs increased the patient comfort, understanding, and physicians, and I'm not sharing this data here, but physicians reported it did not increase the amount of time that they spent and that they would probably do it again. So interventions like this that seem relatively actually can make a big difference when it comes to optimizing the patient visit. How about educating a pipeline of healthcare professionals? What can we do for that? One of the clinics that I started a couple of years ago at Boston Children's is a GI autism multidisciplinary clinic, which also includes KS patients. This is a clinic of physicians, GI nurses, dietitians, even our administrative staff take turns coming to this clinic, social work, child life, who all come. We have as well GI fellows, residents, medical students, undergraduate students, nursing students, dietitians in training. And I say each of those out loud because I want you to know that it is important that we keep building our pipeline of healthcare teams that are our kids well in the future and kids, okay? This is what we have to do. This is part of our job too. Another initiative that I think makes a big difference when it comes to thinking about education professionals, I do a clinic at one of our local residential programs for children with moderate to severe autism where I talk about GI issues. I go to that residential program. I meet with a nurse practitioner, a nurse, a patient's kids, the behavioral therapists, all in one room. In about 20 minutes, we hear what the problem is. We come up with a potential plan. We think about any further tests. They tell me what we can't do because of different reasons based on the residential program, and we adjust it right away. And this has become such an efficient way to deliver care to a really vulnerable population. So I think this is another thing where we're educating healthcare professionals. Everyone who's in those meetings has something to add each other about how to improve the care for our patients. Collaboration with local, national, and international colleagues. So as I mentioned, Dr. Sid and I are colleagues. I work with him often. He and I send patients back and forth all the time. The Autism Spectrum Center is also a big source of referral for me. I see lots of kids with KS, and some of them are here today. I interact with GI colleagues around the country with similar interests. We're actually starting a special interest group in thinking about children with GI problems who have KS, as well as other genetic diagnoses and autism and other neurodevelopmental diagnoses. And this is almost officially made, but it includes people across North America. So gastroenterology colleagues across North America who are interested in this. And then one of my favorite things is an international collaboration. So over the past year or so, I've been working with Dr. Kleefstra's team, Dr. Palmer's team. So, and we have meetings where we're talking about where we've created a consortium to look at GI problems in patients with KS. I will tell you, the hardest part about this is scheduling a time that works for Boston, the Netherlands, and Australia all at once for all of us to meet and no one be in the middle of the night. It is virtually impossible. But otherwise, this meeting and this consortium has been absolutely amazing. And some of the data that I shared with you already and pulling it together. And that's going to lead to combining our collected data, having sort of thought when it comes to GI manifestations, And then also we're already working on a prospective survey collection on GI nutrition factors for children with KS. This is something we're already trialing right now. So I will end actually with a quote that one of my mentors always says, which is that progress only happens when you have collaboration with a healthcare team and patients. So this is really my hope for today. I appreciate your time. I am open to questions, comments, suggestions, all the things. And I would love to hear from any of you. I have some more slides in there if we had time to chat. Do you need the mic?
I think they want the people watching to be able to hear.
Okay.
On the prospective survey that you spoke about, is that only for your patients? I mean, my daughter's older. I didn't know if there was a way to collect that information, which I think is so through all of that, to try to find, some information that would be helpful to us as families. So is it just limited to your patients?
It's a great question in thinking about who's really eligible to do this prospective survey. It's very much in pilot phases right now. So I'm trialing it with my patients in order to see, does this work? Is this a smooth survey? Are we getting the questions we want? One of the most interesting things is because it's an international collaboration, even the types of words we use are a little bit different. So, for example, in Australia, in the United States, we would say maybe check the box that applies. In Australia, they say tick the box that applies. That feels like a small difference, but it might make a difference as to how to interpret the survey. So we're in those early phases right now where we're sorting out that type of thing. I think if we find something that really works, it would completely open it up to older individuals as well. It's a good idea to keep in mind.
Thank you. This is really very enlightening, so thank you. I have two questions. The first one is, are there any hypothesized gut microbiota modulating interventions that families could try? For example, if something it hasn't been shown to be effective, but there's no real downside. The other question is a little bit downstream. So children end up having hard times toilet training. I suspect it's multidimensional, but I can't help but thinking that constipation, some of the other GI problems are related. Could you speak to that as well?
Thank you for those great questions. I feel like you've just set the agenda for another whole talk, actually. Let me give you at least a little bit of information. I think from thinking about the microbiome in terms of therapeutic interventions is one. I think there's just not good data to say definitively, here's what we want every KS student, every KS kid out there to take on a daily basis. And I would hesitate to do that. I do think that I draw, again, from the autism literature because there's more data out there on that. In the last 10 years, I've done many trials about probiotics, for example. Can we think about probiotics in children with autism? Are there any lessons from those examples that we can draw for our KS kids? It's very inconclusive. Deficiency in certain bacterial populations, when you try to replete those populations and then study that, we don't always see. So I hesitate to say that we have to do something definitively all the time. What I will say that there's good data on, and I want this to be relevant for KS patients too, is there's good data on using probiotics when you have an infection, a GI infection specifically. There's good data on using probiotics when you have had antibiotics. So I will often just say to patients, do this for 1 to 3 months and then stop. See if it made a difference. And if you're noticing after a few weeks, I think it did make a difference, I want to go back to that probiotic, go for it. But I hate the idea of being on medications that we don't know if we really need them or not. So I think that's kind of an underlying theme in a lot of. Your second question was around potty training, toilet training, constipation playing a role? Absolutely. Definitely. Constipation is playing a role. And here's the other piece of it. I think sometimes in those moments when we are in the midst of toilet training, we sometimes think we've achieved success not stooling. And it is true, but there's also a risk that if they're not there's also a risk of withholding during that time, and we're leading to chronic constipation issues that are just beginning to start. So I think in that age range, it is really important to make sure that you have those stools as soft as possible, even though it might feel counterintuitive. And you want to make sure that kids are able to stool without difficulty or pain, because that difficulty or pain is what's really going to set you up for problems down the road. Does that answer your question? Semi? Okay. Tell me how I can answer it better. Yeah. Yep. It depends on the kid. So this is where you really need to interact with the primary care doc or your gastroenterologist and get a sense of what does that actually mean. Because with hypotonia, I would argue that the types of laxatives that you might be using, a softener like polyethylene glycol, even magnesium-based softeners, sometimes may not be enough. Sometimes you need a push medication where you're actually having something to help push those muscles to get the poop out. And I could talk about constipation all day long, and we could talk about it separately if you like, but there are lots of medications that I think are better in kids with KS because we have that hypotonia issue. Sometimes I bring those in early. Sometimes I bring them in intermittently, once a week, even once a month where you do a clean out. So things are a little bit different than I might do otherwise, but I keep it in mind. And even if I meet a family and constipation is not an issue yet, I start warning them about it because of exactly what you're saying, that you can have some soft stool out and maybe not get everything out.
Question over here.
Hi, I appreciate your talk. I have a 4-year-old and we're in Sacramento, California. We saw our local peds GI specialist we were referred to, but it doesn't seem like there's a lot of awareness, perhaps, of the extra specialty of this neurological connection with the GI system. Is there a network of physicians throughout the country who are like you, who would consult so we could have some access, or how do we access that kind of expertise of knowing how to titrate medications for neurological issue? Have that for my kid.
So access of GI doctors and professionals who feel comfortable in caring for kids with KS and neurodevelopmental diagnoses. Is that sort of what I'm understanding from you? How do we access that? Yeah. I think it is more specialized. So this is why one of the biggest tenets right now for me is this idea of educating a pipeline. Because I think the interest is there. It's just we all need to be more coordinated than we currently are. So the group that I was talking about, we have a society called NASP again, the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition. Phew, okay? And this is our major professional society, and we are creating a group within that includes interested individuals from across the country who are interested in caring for kids with genetic conditions, neurodevelopmental conditions, and GI problems. So I am certainly part of that, but I know people in Indiana, in Atlanta, in California. I can't think of someone in Northern California off the top of my head, but I bet I can if we talk separately, who would be great potential. I think we want to start to create those sorts of. We have an opportunity to bounce ideas off of each other, share things that we're doing that are going well and things that are problems. So I think that infrastructure is exactly what I would like to do.
Any other questions? A follow-up?
Former speech pathologist here, going to ask a ton of questions. So a couple of things. Is anyone going to be doing a stool study on our KS kids, like through the Boston Children's Clinic? Also, has anyone discovered through radiographic barium enemas or gastrogafin enemas by chance of some anatomical differences? Another KS young lady, both like 32, have been identified to have redundant bowel, like the colon is got lots more loops. Is anyone doing Botox to the puborectalis muscle in the pelvic floor kind of stuff? Is anybody seeing good results with that? My daughter just had that. And we're just, it's been a rough road the past 4 months with my daughter. So curious to know about maybe some other things happening for our kids.
Sure, those are important questions. I did not get a ton into treatment in this talk because I sort of wanted to lay the groundwork for some of the things that I think would be important to talk about. Absolutely, definitely, we are doing things like Botox to the rectal sphincter muscles. I do those procedures myself. We are definitely doing that at Boston Children's. We are thinking about severe constipation differently than we used to. We're also thinking about Botox to the exit of the stomach because that can cause gastroparesis, so sort of helping on the other end too. So there are different ways that we're trying to think when it comes to KS. I think that it is complicated to kind of consider how do we want to look at all of these patients, do we, and I do think that we do need to have interventions like this, but it's an ongoing process, in terms of how are we looking for the right candidates. I wouldn't say that you would automatically go in and say, I want rectal Botox or I want Botox to the pyloric sphincter, but I think these are the symptoms about this. Does this feel like this is a good choice for my child? I think those sorts of discussions make a lot of sense. Yeah. Yeah. Yep, and I'm sorry to hear about this, the redundant colon. That's really tough. But there are some good solutions out there. There are newer medications, there are surgical options as well that I think, and you kind of need those in tandem in order to help approach that, but that can be really difficult. The other thing that you mentioned that I think is important to touch upon is this idea of pelvic floor therapy. I think that's key. And oftentimes for many of our kids, people and practitioners have said, I'm not sure they can engage in the same way. Pelvic floor therapy may not be a great idea. I feel like we need to be more creative and come up with ways to have our kids engage in pelvic floor therapy. So I'm hopeful that that might be more of an avenue for the future.
I just want to commend y'all for doing the visuals because we all need visuals, and that has been an amazing tool for any kind of therapy,
Oh, that's great to hear. Yeah.
The visuals are so, that makes language concrete.
Yes.
That's very helpful in anything that you're going to do from the medical.
Appreciate that. Yeah.
I've got one question. Speaking of Botox, I was speaking to a mom last night whose daughter's had some luck with Botox to treat no burp syndrome, or apparently her daughter could not burp, which is a burps either. And so they get a gas buildup. There's a flap that's not opening. Can you speak to that a little bit?
Sure. So I think the no burp syndrome actually refers more to the upper esophagus. And so that's Botox that can be injected. Botox we can basically inject everywhere and it does something these days, okay? So that is more injecting it to the muscles in the upper esophagus to allow that to be open in the right time in order to burp. It's actually most often done by our colleagues in otolaryngology, the ENT folks, and not as much in GI, but it's definitely something that can be done and can make a big difference for some patients. There are also some more medical treatments first that you can try as well, but I have seen some success with that.
Let's give Dr. Ballal a round of applause.